Thank you very much. It's such a pleasure to be here. Thank you for inviting me today. To my friends and colleagues in the Dominican Republic, I would like to congratulate you for this 2021 Dominican Congress of Cardiology. You know, ACC is privileged to have Dominican Republic as one of its 42 international chapters. Really is a pivotal opportunity for ACC to build bridges with its sister societies and also identify ways to learn from each other to reverse this epidemic of cardiovascular disease worldwide. I want to offer a special thank you to President Dr. Fausto Worden and the Dominican Society of Cardiology Leadership for their great efforts in these trying times. Though the Dominican Society of Cardiology and the outstanding leadership of the ACC Dominican Republic Chapter Governor Dr. Pura Henriquez and former Governor Dr. Cesar Herrera, the chapter continues to be incredibly engaged in many ACC activities, like our Global Heart Attack Treatment Initiative and Training Directors Work Group. We're launching new ways to get involved and join your chapter by using our online membership application now available in Spanish. So while I'm excited to join you virtually, I do hope that we can see each other in person soon. So thank you for inviting me. And I'm going to go ahead and start my talk. What I'm going to be talking about this is cardiac care in women, sort of the emerging risk factors. I don't have any disclosures for this talk. You know, worldwide, this is not just in the United States, heart disease continues to be the leading cause of death for women. And really, one of the interesting facts is that for the last 3 decades, there's been a little bit of a decline in the heart disease mortality, both for men and women, particularly if they're older, over the age of 65, but we're seeing more of a trend in younger women. So I'm going to talk about that a little bit. Why is it that we're seeing this improvement? Well, one of the reasons is that we really just have a better understanding of sex differences in the physiology of cardiovascular disease, which certainly has implications for diagnosis, treatment, and outcomes. We know, for example, that women are more likely to have plaque erosion than plaque rupture, and that really plaque erosion along with thrombus formation are 2 times more likely in women. We also have identified outward positive remodeling, and we see this more in women. Again, we see in about 1/3 of women that have acute coronary syndrome, if we were to do IVUS, we would see this plaque erosion rather than rupture, which we know is a result of endothelial dysfunction, leukocyte activation and inflammation. We also know that this may be related to some coronary vasospasm, and we know that coronary vasospasm related to myocardial infarction is much more common in women. What about this positive remodeling I mentioned? So this focus on sex differences has really led to the identification of sex-specific mechanism, and we know that women tend to have myocardial infarctions without any apparent epicardial coronary thrombus or stenosis. The last reason for progress is really a recognition of things that predominantly affect women, such as microvascular dysfunction, SCAD, which is spontaneous coronary artery dissection, and Takotsubo's. And so we have to understand that women have more endothelial function, and this really then is associated with the longer-term risk of coronary events in women. SCAD, we know that what SCAD is, it's this non-traumatic, non-iatrogenic, non-atherosclerotic separation of the coronary arterial wall with an intramural hemorrhage that can create a false lumen. There can be intimal tear. We know that SCAD accounts for 2 to 4% of acute coronary syndrome. But interestingly, if you're a woman less than 60, it can account for anywhere from 22% to 35% of acute coronary syndrome. Interestingly, we see this in women that have 35% of women that have myocardial infarctions, and they're under the age of 50 can have SCAD as their reason for their myocardial infarction. Interestingly, this is strongly associated with pregnancy-related associated myocardial infarctions. And in a young woman, the most common precipitating reason for SCAD is emotional stress in almost 30% of the patients. What about Takotsubo's? We know all about it. Now, we're not talking about younger women now. We're talking about older women. This tends to occur in elderly, postmenopausal women after emotional or physical stress. And women have almost a 9-fold higher risk compared to men. And what we know is that compared to previous years, 2016, even just going from 2006 to 2012, Takotsubo's had increased almost 19 times. So there is something, and I think a lot of this has to do with the fact that we're more aware of it, we're recognizing it, And so we're starting to recognize entities such as this. And we know there are many risk factors: emotional stress, physical stress, lots of other issues, endothelial dysfunction, impaired coronary flow reserve. But we know that many, but definitely not all, are associated with a lifetime stressor. What about this issue of women and heart disease? We've spent the last decade trying to educate ourselves as well as patients. But interestingly, this was the data from the Lancet Commission on women and heart disease that was just discussed at ACC 21 2 weeks ago. And what they found was that the awareness that heart disease is the leading cause of death has declined. Now that's surprising. But despite educational efforts over the past decade, only less than 50% of women recognize that heart disease is their #1 killer. And interestingly, primary care physicians, at least in the United States, did not say that heart disease was their primary concern. In fact, only 39% of them said that. And only 16% implemented guidelines for risk assessment for their female patients. So really, the Lancet Commission really brought out this fact that an urgent redoubling of efforts by organizations interested in women's health is required. And this is something we need to do both for clinicians as well as patients. Now, I mentioned to you that although we've done better over the age of 65, we recognize that myocardial infarction in young women may be a distinct entity, and we're seeing more of this. And why is that? Part of that is that there are a lot of non-traditional risk factors. We talk about traditional risk factors, but the non-traditional risk factors are an issue. And most women that have myocardial infarctions, they have a lot of risk factors. They have a high degree of comorbidities. And this was really fleshed out in the Virgo trial because that really made the point. So what are these risk factors? Well, we know about these traditional risk factors: diabetes, smoking, obesity, all of that. But these are the emerging non-traditional risk factors. And this is the message of this talk today. For you to think about the pregnancy-related complications, preterm delivery, hypertensive disorder of pregnancy, gestational diabetes, but also autoimmune disease, so lupus and rheumatoid arthritis. What about if somebody's had breast cancer treatment and received radiation on the left side, or even certain chemotherapeutic agents? And then what about depression, which is certainly more common in women? These are what we consider these non-traditional, but certainly emerging risk factors. So again, it's written here: lupus, 3-fold higher risk of ischemic heart disease; rheumatoid arthritis also elevates ischemic heart disease risk as much as diabetes. Gestational diabetes, there's a higher risk; hypertension in pregnancy, higher risk; depression doubles the risk of ischemic heart disease. So really interesting for us to keep this all in mind. So traditional risk factors, we know about this. This is data from the United States, almost 13.4 million women have diabetes. Most of that is type 2 diabetes. And if you have diabetes, the relative risk for cardiovascular disease is 44% greater in women than those that are men that have diabetes. And a 3-fold excess fatal coronary artery disease risk in women with type 2 diabetes as compared to a non-diabetic woman. What about if you're a cigarette smoker? Well, if you're a cigarette smoker, there's a 25% increased risk of coronary artery disease. Again, if you're overweight, more than 2 to 3 in 3 adults in the United States are considered overweight or obese. And the prevalence is certainly more in women, and that therefore it confers a higher cardiovascular risk. But what about these emerging, the pregnancy-related complications? And let's get into some of that. And, you know, there are many ways that we want to talk about that. Let's talk specifically about women-specific risk factors, and that's pregnancy-related complications. And we know that about 10 to 20% of women will have pregnancy-related complications. And that's important. What are those? Those gestational diabetes, gestational hypertension, preeclampsia, and preterm delivery. And we know that if they have that, there's almost a 2 to 4-fold increase in women that have adverse pregnancy complications in terms of long-term cardiovascular disease risk. What about gestational diabetes? Well, this is what's defined as newly diagnosed diabetes beyond the first trimester of pregnancy. If you have gestational diabetes, you're more likely to have cardiovascular events 7 years earlier than if you didn't have gestational diabetes. There's a 4 to 7-fold increase in risk for later development of type 2 diabetes. And then again, you know, if you're a non-diabetic woman, diabetic women tend to have a much higher cardiovascular disease risk. and a 59% higher risk of myocardial infarction. So it's important for us to get this history. Did they, when they were pregnant, have gestational diabetes? What about gestational hypertension? Well, we know that hypertensive pregnancy disorders are 5 to 10% of pregnancies worldwide. We know that this is defined as new onset hypertension after 20 weeks of gestation. There was a meta-analysis of 9 studies that looked at gestational hypertension, and it was associated with a 67% higher risk of subsequent cardiovascular disease. And it's associated with a higher BMI and hyperlipidemia. What about preeclampsia? Well, we know that this is new onset hypertension after 20 weeks of gestation, but also has proteinuria and end organ dysfunction. The prevalence is 3 to 5% of approximately to 25% of preterm births. Worldwide, this is 5 to 14% of all pregnancies. Interestingly, worldwide, preeclampsia and eclampsia are responsible for 14% of maternal deaths per year, a lot. What are the long-term consequences of preeclampsia? 4-fold higher incidence of hypertension, 3-fold higher incidence of type 2 diabetes, 2-fold elevated risk of cardiovascular death. So preterm preeclamptic woman is at the highest risk. I think important for us to get this history. What about recurrence? We know that if you have preeclampsia and you have another pregnancy, there's a chance of recurrence. That's usually about 16%. And women with early onset severe preeclampsia are at the highest, the greatest risk of recurrence. And so how do you prevent that? Well, low dose aspirin during pregnancy can reduce that risk. But I think that awareness is really an important issue. What about preterm delivery? This is if they deliver less than 37 weeks. Again, 6 to 12% of deliveries in the developed world. The risk is further increased with the history of early preterm delivery. So if you've had somebody that's delivered before the age of 32 weeks, there's a much higher risk of atherosclerotic cardiovascular disease in the long run. So if a woman who delivers a preterm infant are at 40% increased risk of future cardiovascular disease events, while those that deliver before 32 are experience a doubling of their risk, even after accounting for all the differences. So very, very interesting for us to get this history. What about autoimmune disease, rheumatoid arthritis and lupus? Well, we know that the female to male ratio is 2.5 to 1 for rheumatoid arthritis and 9 to 1 for lupus. And again, if you have rheumatoid arthritis, patients with that have 2 to 3-fold higher risk of myocardial infarction and a 50% higher risk of stroke. And then the lupus, the risk of MI could be 9 to 50-fold over that of the general population. So I think that the cardiovascular risk scoring systems really underestimate the burden of cardiovascular risk in patients with rheumatoid arthritis. This is why, if you look at the prevention guidelines, they said that these are risk enhancers. What about cardio-oncology? Well, we know that cancer therapy is more effective than it ever has been. In the United States, cancer survivorships has tripled. And today there are almost 12 million cancer survivors. Well, we know that long-term cancer survivors now represent one of the largest, fastest growing patient populations for risk of premature cardiovascular disease. And what another interesting fact is virtually all anti-neoplastic agents are associated with cardiotoxicity. And we know radiation therapy can lead to fibrotic changes to the valves, pericardium, and myocardium. So important to get this history from the patients. What about really looking at breast cancer? I mean, I think that in the United States, a woman has 1 in 8 chance of being diagnosed with invasive breast cancer at some point. There are, over the last decade, there have been about 3.3 million survivors in the United States. There's an increased recognition of common risk factors for breast cancer, including smoking, family history, obesity, and sedentary lifestyle. And I think that it's important for us to get a history whether they received anthracycline or received radiation therapy. And I think the point is that when you start to see a patient with breast cancer, we need to start thinking about treating them for cardiovascular disease at an early stage, right when they get diagnosed, because depending on what they get, how they get treated, they may be at higher risk. What about depression? Well, we know that depression is increasingly recognized as a risk factor for development of coronary disease. In fact, depression affects women worldwide 2 times greater than men. And it's a significant risk factor for the development of MACE as well as cardiovascular mortality. And women who have experienced a cardiac-related event are more likely to be depressed than men. So I think it's interesting. Depression can cause multiple behavioral habits as well as physiologic mechanisms that increase their cardiovascular risk. So I think that there is a need for improved cardiovascular disease screening in women. I think that we need not only an assessment of traditional risk factors, but these novel risk factors. I think it's important to get a history, pregnancy history, including pregnancy-related complications. I really think we need to continue to do education about heart disease symptoms so that we recognize that there can be atypical symptoms such as shortness of breath or increasing fatigue. I think to tell them about lifestyle, including smoking, diet, physical activity. Really pay attention to the history of stress and symptoms of depression. And I think that we really need to think about a calculation of lifetime heart disease risk and not just a 10-year risk. And I would say, I'm going to end with this last slide, which is that if you're a woman, you got to ask them about sort of a sex-specific questionnaire about, pregnancy-related complications, all of those kinds of things. And so certainly CardioSmart at ACC has a lot of this stuff that we can use, that we can give out and educate our patients. So we should utilize these. And I know some of these are being translated into Spanish, so that can be helpful to you. And I'm going to stop here. Thank you very much. I'm happy to take any questions.